in Nigeria. It's commonly said in this development setting that health reform, so perhaps public policy reform, is more political than technical. The journey towards UHC is a marathon and not a sprint. And like we say in Africa, it's going to take a village. So we're happy to have this group of seasoned panelists as well as audience to join their voices to this very important discourse. Nigeria, with its high disease burden, poor health indicators, and considering the environment of government health spending of less than $12 per capita, over 75% out of pocket expenditure, is still a far cry from UHC goals. And it's not helped by the shrinking macro-fiscal context with less than 10% of tax to GDP ratio. This means that the health sector needs to be politically savvy to benefit from the scarce resources that are available. It was thought that COVID pandemic would increase prioritization of the health sector. However, we're yet to see this happen. Nigeria, like other low and middle income countries, we need to work out a homegrown and locally led mechanisms for advancing UHC goals that will fit our unique context, is applicable to our peculiar cultural, economic, and demographic settings, with a gradual shift to best fit rather than best practice, as we will often say. As different countries have diverse political economic challenges and settings, we would have to use diverse methods that best fit our context to address these issues. In other words, for us to advance on our UHC and SDG goals, solutions must be local for it to be responsive to the needs of our people. This study that will be presented today provides a very good research evidence for Nigeria and similar settings, for homegrown examination and application of our own unique traits using a locally led approach. And this is in consonance with a lot of the policy and strategies that have been discussed all over the world, including the USAID localization strategy, local capacity development strategy, and all other similar recommendations from WHO, United Nations, and all the other important agencies and think tanks out there, including Chatham House, of which we're very happy to have someone from there with us today. I'll be moderating the session today, and my name is Frances Elika. I'm the Palladium Director for Health Systems Strengthening. I provide support across Africa, as well as Asia, Latin America, and other countries in strengthening health systems using a locally led approach. Previously, as Country Director of Health Policy Plus Nigeria, the Health Policy Plus catalyzed the implementation of the Basic Healthcare Provision Fund for the first time in Nigeria, in the first 3 states and the FCT that qualified to receive funding for BHCPF implementation. This was actually a policy that was lying there on the shelf, and there were a lot of political economic challenges, which we'll hear about today, that were preventing this implementation. But with stakeholder collaboration, commitment, and inclusiveness, and people coming together to try to solve the problem, we were able to catalyze this implementation for the first time. I witnessed firsthand the amazing effects that this policy had in communities. In a state like Osun State, we saw villages come to life. We actually saw village people, community members, work development committees gather around their PHCs who had received funding, just very minimal amount of funds for the first time, which they could use to repair leaking roofs, restore electricity to the facilities, repair running water, buy hospital couches. And we saw communities mobilizing to actually contribute and add their own to these efforts, including restoring light to these facilities and even buying some equipment in these facilities. We saw women walking boldly into these previously moribund primary healthcare facilities to receive healthcare, which was not possible before then. That actually showed us the importance of a policy like the Basic Healthcare Provision Fund. I could imagine my eyes, I could close my eyes and imagine this happening in every primary healthcare facility in Nigeria. What a dream that would be. There is certainly some way left to go, and we all have a role to play. This webinar is very rich in that we have an outstanding panel comprising of government actors, academia, global health, global think tanks, implementing partners who work every day in communities to see this come to pass, civil society who are doing their best advocating from day one to make sure that this policy is implemented. In addition to the excellent members of the audience that we have today, who have played one role or the other towards advancing this very important policy, seen as a game changer for Nigerian health financing. I hope you're as excited as I am as we go into these discussions, as we look forward and dream of a developed and prosperous Africa. The session will last for 90 minutes, and we hope that you'll stay till the end. We crave your indulgence. We'll take the presentations, which I must assure you is actually very enlightening and very interesting. And then at the end, we will have a very robust discussion session where we'll have every member of the audience make their excellent contributions from their rich base of knowledge and experience towards advancing this very important policy reform. At this point, I would like to introduce our first speaker, Dr. Gafar Alawode, who is an experienced public health practitioner and seasoned program manager. He has managed several donor-funded projects at senior level in Nigeria and other developing countries, including Liberia and Uganda. He was a country manager for Liverpool Associates in tropical health, state team lead for the DFID-funded Partnerships for Transforming Health Systems. He's the chief of party of the UIC funded Health Finance and Governance Project, and he was also the country director for Health Policy Plus. Gafar has designed and worked with stakeholders to introduce UHC reforms, including innovation like the legislative UHC 2023 forum. He was appointed a member of the core group for Health Financing Resilience, Community of Practice by the World Bank, and is presently managing the DGI Consult Limited, where he leads Prevent Epidemics projects being managed by LISDEL as a project director. He has a master's degree in tropical medicine from the prestigious Liverpool School of Tropical Medicine, UK, and he has a medicine and surgery degree from the University of Ilorin, Nigeria. He is also a member of the UK Society of Public Health of the Royal College of Physicians. Please join me in welcoming Gafar, who we all know as an encyclopedia when it comes to health system strengthening and health financing. Dr. Gafar, over to you. Dr. Gafar, you're muted.
Apologies, please. Good afternoon, everyone, and thank you very much, Frances, for that introduction. We'd like to welcome everyone to this webinar. So this presentation will set the stage for the presenting from the paper that was just published on the political economy of the design of the Basic Care Provision Fund, a retrospective analysis for prospective action. Sorry, trying to move the slides. Is it moving again?
Sorry, Dr. Gafar, if it's freezing, can Ismail help project the slides while you speak?
Okay, I think that's what we are going to do. Ismail, please project the slide. Ismail is trying to present the slide, so a couple of our background information about basic care provision from me, which most of us are very familiar with, because of the health financing landscape in Nigeria, which is characterized by suboptimal public investment in health and high out-of-pocket expenditure, including low coverage of financial protection mechanism. That was what informed our decision to take a giant step towards the reforming the financing landscape in Nigeria. So, basic care provision funds actually part of a bigger reform uh, contained in the National Health Act 2014. And next slide, please. So, which actually articulate a number of intervention, and part of it is the intergovernmental fiscal transfer, which is the basic care provision fund, which basically look at how do we provide additional funding to provide a basic package of essential services to all Nigeria. And then to also incentivize sub-national level spending on health as well. And again, basic care provision fund is also a very, very catalyst for stimulating some key policy trust in terms of making sure we have peace under one roof, and at the same time, decentralization of health insurance. Next slide. So in terms of the study itself, the objective for the study is actually to understand how the role of actors and institutions shapes the design of basic care provision fund, which actually give us a better understanding of what we need to do differently going forward when we are designing health policy. So we use the campus and reach political economic framework, which actually identify a number of stakeholders categories and their policy, so their policies along the leadership policies, bureaucratic policies, budget policies, external actor policies, interest group policies, and beneficiary policies. This is actually a very, interesting categorization of our stakeholders, and look at their peculiar policies interests and how it affects our policy design. Some of the institutions that took part that we engage actually listed here in this slide. So what are our key findings? So I'll be highlighting the key findings along those stakeholders categorization that we've seen. We'll be looking at what are the interests of those key stakeholders, and what is the implication of the interest. How does the interest impact on the design of basic care provision fund? So looking at leadership qualities, and we'll talk about leadership qualities, we are looking at people in the position of authority from executive arm of government and executive arm of government, legislative arm of government at both national and subnational level. How do their interests affect the design? So looking at the Honorable Minister of Health then, he was very, very interested in accelerating basic care provision fund implementation, because we've wasted a lot of time. So the Honorable Minister was interested, how do we move very, very fast? So in order to move very fast, it involved actually waiving a number of conditions associated with the implementation and disbursement of fund. So because the minister was interested in moving fast, and then it was advised by the budget policies, which we'll talk about, so that to make progress, we have to waive some conditions. And that led to the waiver of very important provision, state counterpart funding. And because the Honorable Minister then was interested in strengthening the coordination structure was established within the Federal Ministry of Health. I will later see how interests of others affected some of these things. So in terms of the National Assembly, especially the National Assembly that came on board recently, was interested in aligning the provisions of the implementation of basic care provision fund with the provision of National Health Act. So when the National Assembly discovered that the basic care provision fund was not being implemented in line with the provision of National Health Act, so the National Assembly actually suspended the implementation of the basic care provision fund, and then reintroduced some of these provisions that are contained in the law. So then in terms of leadership qualities, again, one structure that actually played important role as well was the Forum of the Commissioners for Health. It is interesting to note that this forum was not in existence before the introduction of basic care provision fund, but because the Honorable Commissioner for Health at the subnational level were interested in playing key oversight role at the subnational level, they came together to form the forum, and their interest was, how do we replicate the structure at the national level in terms of the oversight structure at the national level? How do we replicate at the state level? And that actually found its way into the structure of the basic care provision fund. So again, we'll be looking at the bureaucratic politics. By bureaucratic politics, we actually look at the interest and influence of the health institutions at the national level, especially looking at National Primary Care Development Agency and looking at the National Health Insurance Scheme. I think one of the part of what we discover is that the national level institutions were interested in having a higher level of autonomy in the design and implementation of basic care provision fund. And they wanted basic care provision fund design to align with their existing policy trust. For example, NPHCD, the key policy trust of NPHCD was PHC Odawanru. The key policy trust, flagship policy trust of National Health Insurance Scheme was State Health Insurance Scheme, Health Insurance Decentralization. And when they discovered that, the Secretariat will not allow them to have the desired level of autonomy, of course, they try as much as possible to ensure that the Secretariat was actually jettisoned. And then Secretariat came into being in the first instance because some donors were interested in part of the oversight and governance of the basic care provision fund. So that pressure actually led to a removal of commingling of resources as well. And the end product is that we have a basic care provision fund that is more aligned to the interests of the national health institution, the like of NPHCD and NHIS. And again, one institution that actually featured was NCDC because it was not part of the original design, but because NCDC had a very influential leadership, they were able to engage and ensure that NCDC is now captured as part of the beneficiaries of the basic care provision fund. So again, looking at the budget politics, the Federal Ministry of Finance and Budget was actually interested in ensuring that the efficient utilization of basic care provision fund. They learned from the experience of the UBEC, which was another earmark fund, how the money was just sitting down at the central bank for most of the states because states were not able to pay counterpart funding. So the issue of a waiver of the basic counterpart funding actually was part of the pressure from the budget office to ensure that before we release this money, you have to waive these. And there was a National Council on Health that took place, and it was discussed, and it was temporarily waived then. And again, part of the condition from the budget office was to put in place a very, very robust manual for how money will be disbursed, managed and accounted for. And that led to hasten design of the initial initial part of the basic care provision fund manual. So external actors, the donors and partners actually play a very important role. And one of the main interests of the donors then was to ensure transparency, efficiency, utilization of resources. And that was part of why they put resources. This is for the pilot in the initial state, which actually give them the opportunity to be part of the oversight of the basic care provision fund, which we were able to do because the guideline then allow for commingling of a donor fund and government fund as well. And then they help in the setting up of the basic care provision fund secretariat. And then both of these were actually contested by other actors, which thought it's actually they are diminishing their influence, and they led to eventual removal of commingling of fund, and then a jettisoning of the base of the secretariat. So some interest groups actually play important role as well, especially the Nigerian Medical Association, and because Nigerian Medical Association was interested in ensuring that part of the basic care provision fund was used for management of emergency, because for a lot of road traffic accidents, and there was no provision for catering for these victims of road accident. That led to earmarking 5% of the basic care provision fund, and then the same structure protested vehemently, seriously, that NCDC was not part of the original plan. When they say health security, when they talk about emergency, they are referring to medical emergency and health security. So this structure led the protest, and initially NCDC was actually removed from this. The Forum of State Executive of State Health Insurance Scheme, they were interested in ensuring that basic care provision fund align very well with the operations of the state health insurance scheme in the country. For example, they ensure that the provider payment system, which was initially designed, was actually removed and aligns with the provider payments in the system of the state health insurance scheme. So some beneficiary qualities as civil society actually play very important role, but it's very important to actually identify that, to stress that the civil society, they play a huge role, especially during the design of the legal framework before the Basic Care Provision Fund was National Health Act was actually approved. They play a very crucial role that ensures the signing into law of the National Health Bill, then that became National Health Act. Then, what are the implications of some of these changes, the interplay of influence and interests of actors and institutions? What are the implications for implementation of Basic Care Provision Fund? We saw how the interests of stakeholders actually changed the governance structure of the Basic Care Provision Fund, especially as it relates to having a coordinating structure at the national level, which then was secretariat. This has implication because when the secretariat was there, it was easy to gather data, to have information about what was happening about Basic Care Provision Fund. Accountability was a lot easier. But with jettisoning of the secretariat, that became a challenge. But it's very important to say that the structure that replaced the Basic Care Provision Fund Secretariat, the Ministerial Oversight Committee, it's possible for that structure to step in and actually probably fill in some of the gap left by the removal of the Basic Care Provision Fund coordinating structure, which was the Secretariat. Then another area was the counterpart funding. So the law made provision for counterpart funding, but at the same time, because of our operational challenges and examples from other related earmark funding, led to the waiver given to the Basic Care Provision payment of counterpart funding. But the National Assembly thought this was not right and to reintroduce the counterpart funding. This has huge implication because if the states are not able to pay the counterpart funding, that means the money must just be lying in the central bank on the account of the state without being able to use. So these are part of the possible implication for it. Again, we saw how an interplay of interests of actors and institutions, especially bureaucratic qualities, ensure the unmingling of donor fund with the government funds. This has implications in terms of could increase the fragmentation of a pool of Basic Care Provision Fund. It can actually reduce the volume of money that will come into the Basic Care Provision Fund, and then, of course, implementation might be less efficient because of the fragmentation that we've seen. There are a lot of argument and counter-argument that this was necessary to ensure local ownership, but at the same time, some stakeholders are very concerned about the possibility of reducing accountability and transparency, including it might increase fragmentation. We saw how the various interplay led to introduction of NCDC as a beneficiary of the Basic Care Provision Fund, their subsequent removal and their reintroduction. I think this has huge implication for health security in the country because NCDC was actually able to display how they were able to use the money effectively in the past. So we'll now go to what are the key lessons learned and the recommendation. I think part of what we learned from this study was that it's very important to deploy a participatory approach to design of any policy, which we include mapping of our key stakeholders and identifying their interests and influence, and trying to see how best to manage the influence and interest from the beginning so that we'll have a more seamless implementation of policy. Then it shows that we have to strike a balance between the speed of policy design and effective stakeholders' participation, because we saw how the need to quickly design the program and implement it because we have wasted time led to non-inclusion of our critical stakeholders, and how this actually slowed down the process in the press. Part of the lesson that we learned that is very important whenever we want to start the process of design of a policy, to deepen the knowledge of key stakeholders on the concept, on the subject matter of the concept. Looking at Basic Care Provision Fund, the subject matter is intergovernmental fiscal transfer. And we have seen how because of limited understanding of the concept of intergovernmental fiscal transfer, different stakeholders subjected to different interpretation, which actually slow down the process. And again, we see the need to actually align the reform with the existing policy trust. The existing policy trust with National Primary Care Development Agency, which is PAC Odamaruru. The flagship policy trust of National Health Insurance Scheme is actually health insurance decentralization, because the initial process of basic care provision fund is not actually effectively aligned to this, actually cause a lot of challenges. And lastly, the next set of lessons that we've learned. Next slide, please. Okay, the next set of lessons that we've learned that is very important, because Nigeria is a federal structure, to engage stakeholders at subnational level effectively. And of course, some stakeholders express concern that disbursement of basic care provision funds should not just be based on the population of state or the poverty index, but it should take into consideration health system performance in the state as well. So again, we discovered that there is need to improve the coordination structure of the basic care provision fund for us to achieve the needed stuff. And the bigger recommendation that are going forward, I think we need to look at the need to actually achieve more fiscal devolution, because of imbalance between resources accruable at the national level and subnational level, which impact on ability of the subnational level to spend effectively on health. I'll leave you with the last quote, which actually I think from one of the respondents, which summarizes the whole essence of the political economy as it involves policy design and implementation. One of the respondents told us that 90% of the argument that they had that stalled the implementation of basic care provision fund were more of issue of incentive distribution than a real technical issue. So thank you very much for listening.
Thank you so much, Dr. Gafar, for that stimulating conversation. It's actually quite interesting to see how this interest and influence played out in actual implementation of the Basic Healthcare Provision Fund. It was quite interesting to hear about the need for trade-off between speed, inclusion, but also perhaps in best design. So there were some desirable things that would have led to better outcomes, but there needed to be a trade-off if we actually wanted to see this policy implemented. And then of course, you highlighted the need for citizens' participation, which could have helped to actually address some of the issues that had come up. So thank you so much for that. You've left us with a lot to think about. Now we want to go across the Atlantic in order to get a wider perspective on some of these issues. And it is my pleasure to actually introduce my teacher, Professor Dina Balabanova, who is a professor in health systems and policy at the London School of Hygiene and Tropical Medicine. She has over 25 years of experience in research on governance, effective delivery models, and health system strengthening. She leads a portfolio on good governance and anti-corruption research in Bangladesh, Nigeria, Tanzania, and Malawi, in addition to research on health system responses to NCDs and creating learning networks. Professor Balabanova led the Good Health at Low Cost projects that examined how different countries, including Ethiopia, have made major advances in health and access to services than others with similar income. Actually, when I was in school at the master's program at the London School of Hygiene and Tropical Medicine, Professor Dina's paper was seen as the Bible when it came to health systems. She was a Health Systems Global Board member from 2012 to 2018, and she sits on the technical team of the Lancet Commission on PHC financing for low and middle income countries working on political economy issues. So we're quite privileged and delighted to have her here in person with us today. So Prof. Dina, could you share with us some of your experience seeing that the Lancet Nigeria Commission on PHC financing expounds on the political economy of PHC financing reforms? Could you reflect on how the political economy shapes PHC financing reforms in low and middle income countries, drawing from your experience across board in countries with similar settings? And maybe perhaps also share with us how policymakers and stakeholders can leverage political economy knowledge to advance PHC financing reforms. And then finally, if you could also take a little time to reflect on how best do we engage different actors, seeing all these challenges, seeing the different trade-offs. How do we work in anticipation? How do we engage to get the best fits and the best design for major health reforms? So Professor Dina, over to you.
Thank you very much. First to check, you can hear me okay?
Yes, absolutely.
Thank you very much for this opportunity to contribute to this seminar. Apart from what you said about me, in the past 2 years or 3 years, I've been extremely interested in the political economy because I'm starting to realize that we can't talk about health system strengthening without really addressing issues around political economy. So maybe I've been wrong all this time to look at other issues. So this report, I was part of the technical team with a broad range of commissioners working on the rethinking primary healthcare. How do we finance new models of people-centered primary healthcare? We started with a very technical approach, is looking at how we mobilize resources, how we allocate resources, how we create accountability framework. However, ultimately, during our analysis, we came across all these other factors which relate to the political economy, and that's not something we envisaged. We looked at a lot of country experiences, and we realized that there is something bigger there that regulates how health financing reform is implemented, designed and implemented. So I would like to tell you a little bit more about our findings, just in that particular element. So what we found that actually, if I can summarize, one of our key messages that the political, the social and economic conditions are equally important as the technical elements of design and implementation of reform if we are trying to implement reform which improves equity and efficiency and create a better health system, such as, for example, the Basic Healthcare Provision Fund in Nigeria is one of those initiatives. So sometimes I would say not even equally. Sometimes the political, social, economic conditions are leading. They're shaping what's possible. Then what do we mean by political economy? We mean really the power dynamics between different stakeholder groups in relation to distribution of resources and how this is shaped by the economic and social condition in a society. However, when people talk about political economy, very often we notice from our reading of the literature is that people often talk about it as a constraint to reform, as something which creates problems or tensions. However, we focused on how this situation or political economic factors could also create opportunities, how they can serve as entry points to accelerate reform. So then what we said is that we shouldn't do what people usually do. They do the technical solution and then they start to think, oh, how do we implement it? How do we map all the actors and convince them to get together around that? We argue in our commission that we need to do that even before we start designing technical solutions. And that's why we talk about politically informed technical strategies. And these, I would like to emphasize, these are always in flux because the political economy changes. And I think that's one of our problems. We have a good strategy, but then the situation changes in some way. There is a funding shortage, or there is COVID, or there is something, and then we have to go back to the drawing board. So just to a few words around, sorry, for some reason, I can't, oh. So this is the framework we used in the Lancet Commission. We used quite a simplified framework because we didn't want to make it very inaccessible. We wanted really to engage with a broad variety of stakeholders. So we looked at the politics, these are the power relationships between people, organizations, and the political representation and mandates. We also looked at the social conditions. These are the social capital, social relationships and norms around inequality, what people are prepared to tolerate, Then the economic conditions. This is the level of wealth, the economic development, and structures in society. Again, as I said already, this was all around how do we provide patient-centered healthcare financing for primary healthcare. And these domains are interrelated, and that's, I think, one of the difficulties. So I would like to give you just a few examples very briefly, and then move to what do we do about it. So the politics. We all know, and I think we heard Dr. Ghaffar talking about this in length. We all know that there are different actors involved, but what was really surprising to us when we looked at cross-country experience was that it's not always the usual actors, the actors that we would expect to care about primary health care. It is very different in different countries. So for example, in Brazil and Costa Rica, strengthening primary healthcare financing was part of a social movement that was much outside the health system. There was a social movement towards enhancing the rights of vulnerable groups of the population. And then what happened, there was a process, political process, which is outside the health system, which led to various entitlements being incorporated into a social contract and ultimately into the national constitution in the 80s. However, in other countries, such as Ethiopia or China, this was not so much grassroots-led model. This was situation where political leaders, parties saw the value of equity-oriented reforms, for example, expanding insurance in China or expanding primary healthcare delivery models in Ethiopia. And they saw this as a part of a way to capture and increase support in the population around a shared understanding of development, social development strategy, again, beyond health. So what we noticed is that the early collaboration is important. I said before even you start designing the reform. So one of the things that we saw across countries is the type of groups, who are the people who are important in this. And Dr. Ghaffar talked about some of those. What we notice is that usually we talk about policymakers and the need to get them on board. We talk about NGO, we talk about various other district level authorities, but I think these are the four groups that we saw that they have to work together. And these groups are the political leaders, clearly. Then we identified bureaucracy. So you could have a wonderful political program, but actually the bureaucracy is not able to deliver their constraints. There is a lack of willingness, and that has happened in many settings. The next thing is to have embedded technical experts. And what do we mean by that? This means technical experts that are listened to. They are part of the government structures. And we saw this in many countries where there are technical units within the ministry that are able to provide real-time support. Then, of course, the social activists. And we saw this from the previous presentation. So why do we need all these groups? And it's not just one or the other. We have to have all of them working together, because one reason is to augment the skills that are there to support reform. But the second important reason is to reach a wider range of constituencies, because in every reform, there is opposition. So if you get this different type of people with different skills, you are getting quite a broad range of inputs in the reform. So how can these actors work together? So another thing is, very often this is difficult. They are divided, they're in different parts of the landscape. So some of the things we notice in countries is that there are a variety of ways. Sometimes they're temporal. So we saw in Estonia, for example, there was a gradual process after the transition from communism. There was an alliance where various technical actors who developed the concept of family medicine as a cornerstone of primary healthcare led the way, but also involved different ministries, not just Ministry of Health, but also the National Insurance Fund, the Ministry of Social Affairs. So there was this very broad coalition, and it was not seen as just reform done by the Ministry of Health, which is often not as powerful in some countries. Again, the whole of government approach, that with the achieving coherence between policy of different actors, and this was quite rare to find examples of that. And that was one example from Brazil, where the municipalities who had multi-sectoral powers, they actually they led this process because they were outside the health system. They were not affiliated with one sector, but they had the links to all the sectors, to all the actors. So they were seen as a credible candidate to hold, to advance reform, to advance primary healthcare reform. They were very instrumental in that process. And again, I think very important point is not to forget about the technocratic elites and what we call social entrepreneurs or policy entrepreneurs who provide vision. And in some cases, we have seen where individuals, one person has created an idea which was then taken on by others. So again, there is a constant contestation. That's unfortunate. These alliances are not stable. You showed us the table, Dr. Ghaffar, there were a lot of different actors and priorities change. Constituencies demand different actions and the priorities change over time. So just a few words very quickly about the economic factors. I'm not going to go in depth, but just to mention, when we look at the country, so what is important, the structure of the economy, how much of the firms and businesses are in the formal sector, how much can insurance do and reach those, what are the economic cycles of development of growth. We noticed that despite what I said in Brazil and various countries in Latin America, Chile, Costa Rica, we see that despite political will and a lot of good reforms, actually the economic growth was what made reform progress. The structure, the provider market and incentives. So in the social aspect, I already talked about the social movements, the importance of what people can tolerate. So China, for example, is a country that accepts inequality. Seem to be, there is a lot of sort of these social norms, but there was a lot of social grievances in the 90s when for periods of time, the out-of-pocket payments became extremely catastrophic and people, there was this sort of disquiet where the government really had to intervene, I think, to keep the social sort of harmony. And of course, in Nigeria, I think we are talking a lot, but that what Dr. Ghaffar said about the importance of really getting the local authorities on board, the different subnational authorities in order to promote insurance. And again, the social contract, we saw this almost everywhere. There needs to be some sort of social contract around major reforms. And I believe the reforms you are now implementing in Nigeria fall in this category. They're quite a major thing that the society has to accept. And that's what we've seen in various countries. However, their crisis, so their constant crisis, it may be that suddenly there is another change. I think building resilience is really important, thinking about what is it that can be done to build resilience. So having said all that, I have just 2 minutes on what can be done. As I said, we argued in our report, in our work, that political economy is something that can be harnessed for achieving wider societal objectives, development objectives, not even in the health system just. Again, what is it that we can do? Several steps. So the first step is we need to have these politically informed strategies, which I mentioned. So how do we do that? The first step is to ask the questions in the beginning of reform, when reforms are being designed. And I think it's very important to understand who is affected, who is going to support, and really undertake stakeholder analysis. But even deeper than that, we need a very clear understanding about incentives. Why would some actors support this? Who are the actors who can be attracted to support this? What are the possible coalitions and pathways to change? There needs to be some sort of clear process. And we saw this in a lot of countries. Turkey started to implement primary healthcare reform 7 times, but there was never the right alliance, the right political moment economically. And in the end, this was done, but it took a lot of time and the pathway was quite torturous. And the sequencing is important. So the second big point is that building capacity on engaging with political economy. And I'm just thinking, Dr. Ghaffar, there are not so many maybe people like you who understand the context. So how do we do it in the health system? How do we bring this expertise? And our, I think, point is that it's difficult. You really have to bring it outside, from the outside of the health system, and to have this coordination or sort of cooperation between different actors to try to engage with different actors who are outside the health system. For example, there are actors who are interested in social development and they're interested in improvements in the health system from a different perspective, not because they are health actors, but they are interested in wider societal improvement, accountability, improving access to public services. So some of these actors have good knowledge and could be part of the reform process. And then finally, I think one thing that we saw that very often in when we look at the history of healthcare financing and the role of donors across different countries, the role of governments, a lot of the strategies and measures and reforms have been reactive to a crisis or problems in the country, or new government comes with an idea and they start implementing. But I think what we argue that there needs to be a strategy, long-term strategic plan and pathway, and then taking opportunities, but also managing and being very responsive, not just responsive, but anticipating change, which inevitably happens. And thinking about the tactics of how exactly you do that, who are the actors who can work today or what happens next. So this is it. But I would like to just finish by saying everything I said, it's fine, but the reality is that these things change really quickly. You could have elections next year and you could have slightly different group of actors there. So how do you manage this situation and this evolving balance of power? I think having what I already mentioned and what we talked about in the book, Good Health at Low Cost, is having this long-term vision is really important in any area. And I think this has helped for governments who had these long-term coalitions and visions, political sort of coalitions, they appear to be more successful in maintaining momentum. Again, when people know where they're going. And then finally, I already mentioned the need for flexibility, responsiveness to change. And often this includes strategic compromise, focusing on what's politically possible at that point in time and thinking about stepwise or pilot-based reform before there could be a national expansion, or to think about what are the ways to anticipate change and prepare reforms, prepare these technical elements while waiting for the right moment to implement it. Thank you very much.
Thank you very much, Professor Dina, and thank you so much for highlighting the need for us to be proactive rather than reactive. I would like to move on very quickly to the next panelist, who is Professor Aliko Ahmed. A lot of us know him. He comes from Chatham House. Recently, Chatham House has been providing a lot of support to Nigeria in UHC reforms, especially in regards to engaging politically. So Prof. Aliko Ahmed is a public health physician, epidemiologist, and global health diplomat with 3 decades of working experience in clinical medicine, academia, and public health in low and high middle income countries. His global interest is in sustainable health solutions, particularly in the translation of evidence to relevant and appropriate public health development and implementation in Africa. He is an associate fellow and convener of the Public Health Policy Forum at Chatham House, a forum that supports African leaders towards development and implementation of asset-based health policy for their countries. He's a strong advocate for sustainable health systems in Africa, and he is a commissioner in the Global Initiative on Universal Health Coverage. He has held several senior professional and executive leadership roles in the NHS and local government in the United Kingdom since the early 2000s, and he's currently the Regional Director of Public Health for the East of England region. He's also an Associate Director at Cambridge Public Health and a Fellow of the Wolfson College at Cambridge University. And he shares the UK Faculty of Public Health Africa Group and holds honorary professorships in public health at several universities. You're welcome, Professor, and it's an honor to have you join us today. Please, if you could take the next few minutes to share with us your thoughts. We know that Chatham House is a renowned international policy think tank with outstanding convening power. How does the Chatham House use its convening power to shape and promote health agenda in low and middle income countries? And perhaps how can Nigeria benefit from all of this? Over to you, Professor.
Thank you very much, and good afternoon to everyone. Thanks for the invitation. It's great to be here. I have a couple of slides because I was asked to talk about two key issues, and I thought maybe I should just run through those slides and then have an opportunity to discuss with you guys. I don't know whether the slides are on, Francis?
Hi, Ismail, please could you put up the slides?
I can talk without them, but if they are there, that might help.
Yeah, I think you can get going while Ismail is trying to put it up.
What would really be what I'm looking forward is the conversations. I think that would be really enriching. So I'm asked to speak about two things. One, just in terms of what Chatham House is doing in terms of the global health development on UHC. And then secondly, what we're doing with Nigeria. And just to maybe start by saying that I'm really delighted that Gafar and Dina came before me because they highlighted all the kind of essential components you need in order to achieve universal health. But for Chatham House in particular, our interest in the political economy. So we recognize the value of technical abilities, funding, but political economy, because we completely believe that health is political. It's choices that have to be made by political leaders to determine whether they can invest and improve outcomes for their population. If I may say a couple of things then about what we do. The next slide is just an introduction. I think the moderator has talked about Chatham House. You might all know now we are almost 100 years old. And Chatham House has always had this uniqueness in an ability to have expert policy analysis. But I think what made Chatham House stand better than most places is its independence. So regardless of the political power or resources, you don't determine what the content of a Chatham House program will be or its report. And I think that is what is very attractive to people. And it has been an international convening space for as long as we can remember. So that political independence and ability to facilitate debates between different political actors is helpful. But not only then the analysis, we try to put policy options for consideration by different countries in particular. About 4 or 5 years ago, we realized the importance of focusing on health, and we created a Center for Universal Health with specific expertise around political economy and health financing. And the idea is therefore to optimize our skill set and provide advice to countries at all levels of income. Similarly, about 5 years ago, I created the Public Health Policy Forum, which is a subset of the center. And the main idea of that forum is to focus on Africa in particular. We're all aware that copy and paste options don't work, and this forum really look at contextual reality. So while we look at policies that are not only relevant, but they are appropriate to sustainable development in Africa. Over time, you will agree with me that we have been brainwashed to think that most of what happens in Africa might not be too good, but we have a lot of capital within Africa that is very good for health, that is very good for well-being. And what this forum is trying to do is to ensure that whatever policy option we are considering is tapping into that element. That is why our mantra, you can go back to I can leave that slide for now, please. I think it's important to highlight that the policy forum, really, we look for what is strong in Africa rather than what is wrong. And that means we are not focusing on epidemiology, which tends to always tell you what you don't have. But we focus on the community asset and the strength of the societies in Africa, because that is where sustainable approaches can be maintained. And I hope we can have some conversation on that. So that's what the forum has been doing. And we do have, every 2 years, we have a session that is focused on Nigeria. And we've had 3 of those, including the last one, which was in September. And we tend to invite most of the political leaders, not only to speak to Nigerians who are global, but also for them to interact with other global health partners to understand what might be helpful to Nigeria at the same time. And I think it is probably fair at this point to also say that one of the successes of the forum, which I was hoping Gafar would have mentioned, was our contribution in facilitating the agreement for the Better Healthcare Fund that was agreed. That was a pointer in one of our sessions where the minister and the then Senate chair agreed to work together to ensure the Consolidated Revenue Fund passed through the necessary legislative process. So we contributed to that, and we're very delightful to sort of get that experience. Going into the next slide, please. I think my main focus today is just to talk about what global initiatives we are taking forward on universal health coverage and using COVID experience as a catalyst. I think we all recognize the challenges that has come through with COVID, the fragilities and vulnerabilities within society that has been exposed, the exacerbation of health inequalities, all of which has made really society to think about its contract with its government. There's a requirement for states now to intervene much more than it was before. You're aware in the UK system, for example, when we had COVID, the furlough scheme was established, providing social protection to people, where 80% of your income is protected and you are just expected to comply and stay at home. So those were interventions that were unprecedented before, and society requires that. We've seen responses where access to healthcare and social financial protection across the world has been sort of thought in a different way than it was before. But most importantly, we're seeing a universal demand for health. Society is rising up, citizens are asking for their entitlements, and population wants more results than ever before. And that is creating a lot of solidarity for universality. And we feel that universal health coverage provides a perfect opportunity to go into those, to take the opportunities of the crisis. Then the next slide is just an example of the different leaders in the world where they are facing different challenges. Sorry, next slide, please. And I think most of which you are familiar. Sometimes crisis provides opportunities. We've seen leaders who have stood up to respond and do something. We've seen leaders who have fallen down their sword because they were not able to do that. But what is really helpful is universal health coverage has really taken up and it's on the top of agenda everywhere, including among many of the African countries. And we are very, very excited to ensure that we continue accelerating that. And that takes me to the next slide, actually, which is to just introduce to you the work that we are doing now on what we call the Chatham House Commission for Universal Health. Next slide, please. So this commission is just been launched this year, and it will run for 2 years. It's been chaired by the former president of New Zealand, Helen Clark, and the former president of Tanzania, Dr. Kikwete. So they are the chairs, and they are supported by 40 commissioners that have been drawn from across the world who are experts in health economics, politics, public health, private sector, civil society. And the idea of that is to optimize all we know and push forward to inspire and encourage political leaders to either launch or to extend the universal health reforms that are currently taking place. For those who have started to extend it, for those who need support to be supported. And we are very clear, our audiences are the high-level political leaders. That is, it's very good to know what the audience are. And we have 3 questions that we are pulling together. One is this constant debate about what is universal health, what is universal health coverage. There is no one standard definition of it. And we are very clear when we say universal health, we are referring to the universal health attainment of health, while universal health coverage is a means to that end. And for many countries, universal health coverage is the starting point. And why is it important for political leaders to take it forward? I think we recognize sometimes the argument of health outcomes doesn't always guarantee success with political leaders. What we are looking for is where they can see the economic benefit, but most importantly, the political benefit of it, where you can become a legacy leader or institute something to get you into office and power. The second one is to recognize that there are so many different drivers and opportunities that made countries to go into transit into universal health. some are crisis driven, some are financially driven. Dina just gave examples of those. And what we are trying to do is to try to study and understand what makes countries move to universal health. What are the positives? What are the challenges? And that gives us sort of the distillation of the key points that can be used for learning. And then the last one is to look at whether the crisis in the 2000s has allowed for that. The last few slides is just to focus on why Nigeria. So the next slide is to say the giant of Africa, as we affectionately call our country, there's no question about its strategic importance. But as one of the countries with the largest GDP, it is a bit surprising, rather, that the country is still dragging its sort of position in terms of where it should be. So we hope that some of these things will try to help people to kind of focus on where they are. The third one is to show that, the next slide as well, is to show the importance of political leadership. There is a direct correlation between life expectancy and the quality of the democracy you have. We are in an election period now. I think quality of the elected leaders we have will have a direct impact in terms of the life expectancy. And I think this is something that probably civil society should try and maybe inform the colleagues as well. Their vote matters on how long you live and how healthy you live at the long run. The last one is to say what we are doing on the slides in terms of partnership with Nigeria. We have that long-standing partnership, and we have new partnership with the UHC Forum, which I think are doing brilliant and well done to Gafar and colleagues like Muji and others who are in that forum. They are translating evidence into action directly, which I think is very positive. Our partnership is intended to use Nigeria as a case study to understand the drivers of what is making Nigeria move faster or slower, but hopefully faster. And also to build on some of the excellent things that have been done, like the Lancet Commission that has just been launched recently, which has provided a very comprehensive analysis and a roadmap for the country, a brilliant piece of work. So those are, I think, drivers for success, and I hope the journey now will be able in the next year or two to allow us to have a very compelling case in Nigeria. And then there are two other things that we're trying to do now to ensure we're seizing opportunity to deepen understanding, using the UHC Day as one opportunity, working with the Governors Forum. And we're trying to establish a very strong political leadership for UHC, creating UHC champions, creating a cohort of leaders through the Governors Forum and the ministers, but also linking them up with similar like-minded leaders from across the world, either governors from other African countries or other countries are far from that. Because I think only leaders sometimes understand the motivation of other leaders. So I'll leave it there. I'm talking so fast because I have a few minutes, but I look forward to the conversation, Chair. Thank you very much.
Thank you very much, Prof, for that excellent contribution. And thanks so much for pointing out the fact that we should focus on strengths rather than weaknesses, and all the excellent work you're doing to drive political leadership. At this point, I think we're going to come back home, and the next panelist is Dr. Kofi Abubakar from the National Health Insurance Scheme, who is a medical doctor with a master's degree in public health and MBA in international healthcare management from the Frankfurt School of Finance and Management. He's presently the Deputy General Manager and Head of Policy, Planning and International Collaboration Division of the Nigerian National Health Insurance Scheme. His major responsibility is to coordinate and implement interventions to advance the cause of UHC in Nigeria. And in addition, Dr. Kofi convenes health and social research under the NHIS with focus on strengthening health financing systems in order to improve the functioning of the health system. It's great to have you, Dr. Kofi. Please, could you speak to us very briefly within the next few minutes about the recently signed National Health Insurance Act, which introduces a number of reforms, such as the creation of the Vulnerable Group Funds, which will leverage on the BHCPF, as well as mandatory participation in health insurance, which creates the potential enabling environment for universality. So how would the National Health Insurance Agency approach implementation of the NHI Act in light of the emerging evidence of how political economy evidence shapes policy design and implementation in order for us not to make the same mistakes again? And then what are perhaps the most essential things that the NHIA will do differently to advance our UHC in this country? Over to you, Dr. Kofi.
Thank you so much, Frances, and good afternoon, all. And my discussions would narrow down to really what we are operating, what we are doing in the NHIA, especially as regards to the implementation of the National Health Insurance Act. We are all aware, of course, the massive reforms that are currently happening in the health insurance landscape in Nigeria under the leadership of Professor Emen Sambo, the DG CEO of NHIS, who sent his regard to this very important gathering. I also want to highlight some key lessons that we have learned from the study and how these lessons can influence in the short, medium, and long term the implementation of the National Health Insurance Act. So, okay, so I'm trying to move to the next slide, and I think it's not moving. Okay.
Can we have Ismail?
Okay. Beautiful, yeah, sure. Okay, so I think it's moving now. So just a background, we're all aware the NHIA Act was signed into law by President Muhammadu Buhari on May 19, 2022. And of course, it repealed the previous National Health Insurance Act 2004. This is a landmark achievement of this administration because it set the stage for the legal, and operational framework for the attainment of universal health coverage in Nigeria. The law makes health insurance mandatory for all Nigerians. And not only that, it also gives hope to 83 million vulnerable Nigerians, in line with the Lancet Nigeria Commission report. So this is a law that actually looked at the space of the healthcare space in the country, and really is developing targeted, policies that are aimed at addressing those that need healthcare the most, that is the most vulnerable. The law has some is different from the previous National Health Insurance law in the sense that it has some very critical modifications. Number one is that it changes the nomenclature of the NHIA from National Health Insurance Scheme to National Health Insurance Authority. This change in nomenclature may sound theoretical, but it has a lot of implications. A scheme is just a sort of program or something, but an authority, first of all, is something that connotes power to regulate, power to coordinate, and power to give oversight. The law also, in terms of nomenclature, changes the composition of the board of the National Health Insurance Authority, making the board more broad, more inclusive, and then bring in stakeholders from all the sectors, including CSOs, to really take ownership of the health insurance landscape in the country. But perhaps the most important change in this composition of the board is the exclusion of hitherto stakeholders who actually the NHIA was supposed to regulate, but they were also part of the board. So the board has now been, the NHIA will now have a board that is relatively free to actually operate its mandate as a health insurance regulator, implementer, and coordinator in the country. The law, as I said, makes health insurance mandatory. It also makes provision for the creation of the Vulnerable Group Fund. The Vulnerable Group Fund is an ambitious attempt to really mobilize resources by the government to provide health insurance for 3 million Nigerians. As I said earlier, as I go down, I will give a detail about what the Vulnerable Group Fund is about. But the law also has given recognition and legitimacy to the centralization of health insurance services in the country. So hitherto, the state health insurance, the state health insurance agencies were operating, and without that much alignment with the National Health Insurance Agency authority. But with this law, there is a legal and operational backing for the NHIA to really coordinate and regulate the implementation of health insurance at national and the state level. It also took into cognizance the political nature of Nigeria, in the sense that, you know, our states have their own, various states have their own laws and guidelines that, so the NHIA will provide that universal direction guidance, while the states have the liberty to develop health insurance schemes and implement based on their own state level political, economic, and other social peculiarities. Of course, there are a lot of operational modifications in the way health insurance will be implemented in Nigeria. I will give some background as we go down, some details as we go down. And then, of course, it empowers the NHIA to regulate health insurance implementation in the country. And so the stage, as I said, is set for universality for health insurance implementation in the country. So this is just a narrative to say that with this law, health insurance is now mandatory for every Nigerian and for every legal resident. This is what is captured in the act. And also some modifications that have happened in terms of the law is that the NHIA will now drive the provision of a basic minimum package of healthcare services to all Nigerians. Not only that, the NHIA will also lead in the implementation of health insurance, leveraging on the state social health insurance scheme, and private health insurance will only serve as a kind of supplementary or top-up. So every Nigerian will have to key into the health insurance at the national level, as it is done in some other countries like the UK. If you want to have a top-up, you can actually buy private health insurance, but you will contribute one way or other to the national pool. This is very important in the sense that it will help the resource base of the NHIA to really build up to the level where it can actually provide health insurance for those who cannot afford to pay. Of course, it gives the NHIA power to sanction and regulate, and it also gives us power to review tariffs on a periodic basis and to resolve disputes across all stakeholders. So these are the key changes that this law has empowered the NHIA to do. And for us in the NHIA, what we did after the law was signed was that we sat down and said, okay, let's translate this law into like a guideline, or let's develop a roadmap for the translation of this law into reality. And so we had 6 thematic areas. There are 5 thematic areas that we really felt are very important for translation of this law into reality. Number 1 is legal and regulatory. So we're looking at what are the laws that need to come up again, or what laws need to be remodified. For example, it is going to be from what for you to register a company or to get a contract in Nigeria. We are saying that your staff must be registered under the health insurance in the country. So what legal modifications needs to happen in the Corporate Affairs Act, or what in the Procurement Act of the country? So all these are changes that we're envisioning that will need to happen. Administrative and financial issues, of course, for example, the Vulnerable Group Fund is going to be implemented, and a lot of sources of funding have been mentioned. How do we translate that Vulnerable Group Fund into reality? How do we get the budgetary provision and the release for the Vulnerable Group Fund? These are also issues that we need to factor in. Technical issues. So how do we convert this law into an operational guideline? How do we harmonize benefit packages across the various stakeholders? So most state health insurance agencies operate different benefit packages. How do we streamline and harmonize benefit packages? How does the benefit package of the Basic Healthcare Provision Fund, for example, speak to the benefit package of the formal sector programs of the various state health insurance agencies and that of the NHIA? Policy and advocacy issues. So we're looking at what stakeholder do we need to meet in order to ensure effective realization of this act? What are those critical bottleneck stakeholders that we need to talk to ensure that the act is implemented smoothly? And then what are those cross-cutting issues there are some cross-cutting issues that cut across these 4 areas that may not fit into any of this. So these are also issues that we need to really address, to ensure that we implement this act. So looking at our study, I just gave a brief guide on how the politics, if you look at the framework that we used, you see an interplay of leadership politics and interest group politics at the legal and policy and advocacy thematic areas. So here you will see, for example, the role of the National Assembly, you will see the role of the Governors Forum, you will see the role of state commissioners of health, state health insurance agencies. You see also the role of key private sector players, HMOs, for example, now that they are asked to do, what do you call it? To play a top-up role. Are they happy? Are they not happy? So the politics that's happening here and that is shaping the implementation of this act is actually more of leadership and interest group. Of administrative and financial, we're seeing a lot of bureaucratic politics and also budget politics happening. So for example, now you want to implement the vulnerable group fund. You want to mobilize resources to cater for the vulnerable, 3 million vulnerable groups. How much is that in Naira and Kobo? If you're looking at the BHCPF benefit package of 12,000, that's about 996 billion. If you're looking at the 15,000 benefit package of the chief chief of the energy, that's about 1.2 trillion naira. So this is a huge sum of money. And so is the fiscal space there for it in the first instance? What political actors determine the release, the allocation of this, is also very important. What politics does the NHIS need to play to ensure that this kind of funding gets released or provided for, And so at this level, these are the actors that we're seeing. At the operational and technical issues, we're seeing, of course, the external actor politics, donors, development partners are offering to provide support in translating the operational guideline to, the law and operational guideline. They are providing technical support in trying to ensure benefit packages are harmonized in actuarial analysis of benefit packages, among other things. Of course, beneficiary politics is also becoming very important. Patient groups, enrollee groups, civil society organizations are actually already drumming up for more inclusiveness, more accountability, more transparency in how this law is going to be implemented. And of course, this vulnerable group one, how do we identify who the vulnerable are, and then how do we harmonize with already existing national and state level social protection schemes that are happening across the country. So this gamut of interplay of various level of actors. So the study is actually really very important as we move towards implementing the NHIA Act, and it's actually, but not to say that there can be of course an overlap of some politics across all levels. We can see, for example, occasionally some external actor politics happening at the legal and policy level, with donors and partners wanting to play a more important role, in how this act is implemented, or vice versa. So sorry. Yeah, so I said, what have we learned? And then key takeaways from this study. Number one, what is obvious is that healthcare reform is political. It's no longer news that for you to really achieve any substantial reform in the health sector, you need to be political, and you need to work with the political stakeholders, and you need to speak the language of politicians. It is also critical to mobilize, involve, and coordinate with all stakeholders. Stakeholder analysis, if you hear the politics of how the NHIA Act came into pass, how many times it has gone to the president and has to be brought back to make one adjustment or the other. I want to give an example. There was an initial case where we made provision for 1 kobo per second telecommunication tax to finance healthcare. That was, it has always, the bill at that time reached the president, but the concern came from the private sector players and other revenue collecting agencies that NHIA is not a revenue collection agency. So therefore that component of the bill had to be stepped down. So I think we need to, and that would have been a game changer as far as resource mobilization domestically for healthcare financing is concerned. So I think what is important is that as we move forward, lesson that we are learning is that we need to broaden stakeholder engagement and participation at all levels. Of course, there needs to balance political, economic, and technical interests across all levels. Of course, this really underscores the fact that there is no free lunch, especially as you are doing a reform of that magnitude. For whatever offer of support, you need to gauge interest of players in the sector before you accept or not accept. Working with evidence is key, especially in making case for investment in healthcare. So when we are making case for the vulnerable group fund, we need to actually come up with data to say, okay, these are the vulnerables that exist. This is how much it takes to cover them. This is the impact it will make if we cover health insurance, if we cover about 83 million Nigerians with health insurance. For example, we ask ourselves, what is the effect? What is the impact if we cover 83 million? How does that affect our maternal mortality, our child mortality indices, our neonatal mortality indices, and even our economic productivity, among others. So we need to have that compelling argument to give to government, for investing in the vulnerable group fund, among others. And of course, accountability is very key, and strengthening accountability across the entire value chain is very essential. Thank you very much for listening to me, Francis. Yeah.
Thank you so much, Dr. Kofi, for sharing that. And it's great to see that you're already applying lessons from this study in your design and intervention. So at this point, I'd like to move on to Dr. Bolanle Olushola Falaye, who is representing implementers at this meeting. So she's a public health physician with extensive health system strengthening, TB, HIV programming, and private sector engagement experience. She has led programs that created access to service delivery in the private sector, mobilized resources from private sector, and strengthened the health system to sustain effective collaboration between the public and private sectors to improve health outcomes. She's the chief of party of the LHSS projects, and she provides strategic direction, technical leadership, program management for successful implementation of integrated health system strengthening and health financing towards the achievement of UHC. So it's a pleasure to have you, Dr. Bola, and to get the implementer's perspective. So the Basic Healthcare Provision Fund, the success story cannot be written without the role that's been played by implementing partners, from the time that HP Plus provided support to actually get the first states to qualify and begin this implementation, to the part that other partners that have been providing support across states, including the IHP project, R4D, LHSS, and all are providing. So could you perhaps share with us, how your project or how implementing partners can actually support implementation of the Pro-UHC policy trust at the national level and in supporting states, and then reflect a bit on some of the lessons that you'll be taking from this study to better improve how you provide this support. Over to you, Bola.
All right, thank you so much, Francis, and hello, everyone. I'll start by giving a few of a brief overview of LHSS. LHSS is Local Health System Sustainability Program. It's USAID's flagship initiative in health system strengthening. It's a global program with the overall objective of supporting low and middle income countries like Nigeria to strengthen their health systems, build sustainable health systems towards achieving universal health coverage. Now, specifically in Nigeria, LHSS aims to strengthen the health system to improve population health and well-being and achieve universal health coverage. And we do this in three critical ways that align very well with universal health coverage dimensions. We work at both the national and the state levels across 5 states where we work. And having gotten that victory already, like so many of the speakers today have talked about how BACPF has come to stay, how that, we are now operationalizing in the state. Our first objective is to expand financial risk protection. We work with the states to ensure that we remove financial barriers and also prevent out-of-pocket spending to the barest minimum so that the poor and the vulnerable can seek health care that they need without suffering catastrophic costs. And we do this by supporting NHIA at the national level and the shares, the state health insurance agencies at the state level. And of course, this aligns very well with the third dimension of universal health coverage, which is financial risk protection. Secondly, we support states to increase the coverage of health services for the poor by supporting the implementation of social protection schemes like the Basic Healthcare Provision Fund that has been talked about so much today, and the Equity Fund. And this is very critical because BACPF is from the federal government and it's a first-line charge. However, Equity Fund, not so much so. Many states in Nigeria still release Equity Fund whenever they feel like. And looking at the example of political economy, we leveraged Chatham House very recently to ensure that one of our state counterparts, Nasarawa State, made political commitment. So you see, the Chatham House, like has been said here today, has that convening power to, get the best out of people in terms of universal health coverage. So what we did was to leverage on that. We cannot pretend that we can do things on our own or that we don't need other people. And that's one basic lesson that everybody here has said today, that political economy actually leverages the strength, the priorities, and the resources of other stakeholders or players in the space. So we do this in terms of improving the coverage of health services, leveraging on Chatham House recently to support the Nasarawa State counterparts in improving commitment towards universal health coverage. So this year in Chatham House, the governor of Nasarawa State committed to making equity fund a first line charge. And that means that it will no longer be released sporadically. It's been regular, but for a few months, it's been irregular in that particular state. And so that is a victory for us. Thirdly, we also support states to increase the proportion of fully functional primary health facilities and also revitalization. And of course, this is a complex healthcare system itself. It's complex because you look about PSCs, you're looking at structure, the human resources, and also commodities. And we support states to achieve this. Now, leveraging political economy, not only can we make our stakeholders and our political leaders make commitments, but also leverage the priorities and the interests of the technical people in the team. So before LHSS started off, and this is what I think Dina was referring to when she said you don't design programs first and then start mapping your stakeholders. You start by mapping your stakeholders. So before LHSS took off, we did a mapping of stakeholders. We had like a 2-month inception period where we interacted with stakeholders. We did a mapping to know who our stakeholders are, who are the players in the field of health financing and in the health sector space at the state and at the national level. And what we did was to identify their priorities, who has the power, who has the interest, and who are the influencers. And then we found out that power without knowledge is not helpful. So a lot of people have power, but they don't have information. And you can assume that somebody is occupying a position, and so he automatically has all the information he needs to make things happen. But they may not actually. And so what we did during our mapping, identify our stakeholders and their interest and what they know about financial risk protection, about improving services coverage and utilizing health facilities. And so we got this mapping that helped us to design a diagnostic framework where we could assess our states, the political landscape, the financial landscape in the state, and even at the national level. So after those diagnostic processes, we went on to have collaborative workshops, like a co-creation process, where our stakeholders were invited, to a central place where we looked at all the things we found, and they validated those diagnoses before we could create our actual work plan. So we had a framework, but we needed to explore all the powers and the influences in the room to be able to design, have a co-creation process that will help us implement. This is a lesson that other partners should draw from. And so it's been a seamless process starting work in this state because we already have these very validated diagnostic processes that we can, implement together with the states to achieve our objectives towards universal health coverage in Nigeria. And of course, I'll go back to Chatham House example where we're just starting. So it made sense to do all the technical stuff. But when we got that invitation from Chatham House, we were quick to recognize the political, economic importance of that gathering. And although we had not even met the governor of the state personally, but we supported the technical team to go to Chatham House. So we could have that conversation. And that platform gave us, the opportunity to have a meaningful, effective conversation where we got about 5 commitments that otherwise would have taken a very long time. So technical abilities are important, but the understanding of political economy helps us to know these priorities, the interest, the incentives of our stakeholders. So we are taking that, we are running with that, and Nasarawa State, as we speak, is the first state in Nigeria to make equity fund a first-line charge as committed by the governor. We'll follow through with the bureaucratic processes, to operationalize this, but that has already been done. And then secondly, looking at the roadmap that we say we're going to develop to cover the poor and the vulnerable in the state, we developed a process whereby we could engage with the state players at the local government level. Now, the governor did say to us in Chatham House that the resources for developing the roadmap to cover the poor and vulnerable has to come from everywhere where the resources are available. And it came to the primary healthcare, primary healthcare financing forum that was recently held in Abuja to tell us how much it has learned by participating in that event in Chatham House and how it now sees opportunities everywhere. He told us, health stakeholders, about where resources are in the health system in terms of the laws and the policies. He gave many examples, from his own experience. And so we are running with that right now to plan a program with the local government authorities in Nasarawa State and also the chairman of the House committees that are very essential to passing bills. The chairman of the House Committee on Appropriation, the chairman of the House Committee on Health, chairman of the House Committee on Local Government Affairs, so that we could actually have a sit-down. And of course, again, to operationalize another very important commitment that the governor made about the employer's contribution to the health insurance scheme. So far in Nasarawa State, all the enrollee deduction towards health insurance for the civil servant that have been coming from the state, civil servants. We've not had any deduction for the local government level. So when we're talking with the state to have a meeting where we can have local government chairman and the union leaders who are going to be very pivotal in convincing their members to, to sign in and buy in to the plan. It's actually a law in the state already to have these compulsory deductions from mandatory deductions from the employee's payroll, while the governor will also make good his word of contributing the employer's contribution of 6% of the biggest salary of the local government workers and also of the state workers. So these are the things that we have learned in terms of leveraging opportunities and strengthening each other. And then lastly, recently we've had a series of meetings called the enrollee town hall meetings, where we met face to face with the beneficiaries of the Basic Health Provision Fund. You see, we need a compelling argument to be able to demonstrate the impacts of the little progress that we have made in terms of health policy reform in Nigeria. So BCPS is big, but it's only as good as the impacts we're able to demonstrate in the lives of people. It's okay to talk about enrollment numbers and how every state is doing well. Almost every state in Nigeria, apart from maybe one or two, have had enrollment of their target population based on the money they have. Over 90%. But what is the utilization of the health services by the enrollees? That is what will make the difference. That will make the difference and the changes and the outcome that we want to see. And so we are holding meetings at the state level, at the facility level with enrollees. That is the whole of society, all of government, all of system approach that we've talked about today in terms of engaging the community members at that level and the World Health Development Committees to sit down together. And our team reports of how much information we've gotten from these enrollees, speaking face to face with their service providers. Some of the issues that we thought we knew, from our assessment, we got even more in-depth information about what the issues are at that level. We heard of issues so things are not so straitjacketed because healthcare system is complex, right? And access to healthcare is a multi-dimensional concept that depends on the degree of fit between the patient and the healthcare system. So we assume that by just zoning them to some facilities and telling them it's free to access services, they will automatically just keep using the services. Initially, we thought they did not know, but our enrollee town hall meeting showed us that a lot of them knew that they were entitled to some healthcare packages free of charge, but then distance access was an issue. So they were in a particular ward and they were automatically matched to a facility in that ward that was a BACPF facility. Whereas on ground, these enrollees, some of them were closer to another facility, BACPF facility in another ward. So these are the lessons that we are learning, that health matters are not so straitjacketed and straightforward, but you need to leverage all of system approach, all of society approach, and all of government approach to achieve universal health coverage. Thank you very much.
Thank you so much, Paula, for sharing those great insights about the need to use evidence-based advocacy as well as political engagement to ensure that we're making progress. It's great to hear about all the progress being made. Finally, we must apologize to our audience, but we promise that we'll try to wrap up very soon. And thank you so much for your patience. So finally, I would want to introduce the last speaker, but not the least, because she is actually a big elephant in the room. She's Chief Moji Makanjuola. We call her Auntie Moji because she's the big auntie to the whole health system. and she's the Chief Executive Officer of ISMPH, a veteran broadcaster. Many of us in Nigeria know her, very experienced cinematographer. And she holds a bachelor's from American Heritage University, as well as a diploma from International Institute of Journalism, University of Washington, as well as different certifications from many schools, including on NTA. And she's retired from NTA, where she pioneered the health and the gender desk. She headed the news department, and she still supplies content jobs. She's been a constant person in driving development reforms, including through UN systems, UNFPA, UN Women, UNESCO, EU projects, working with federal state governments at different levels. She has analyzed several policies. She has trained many journalists on how to report well on health and engage well on health. And she leads a lot of advocacy groups and makes a case for UHC as well as other health reforms. She's a member of the Presidential Task Force on Polio and a Knight Fellow and Pioneer Member, Center for Disease Control, CDC, Atlanta, USA. She's a multi-award winner, Rotary International Paul Harris Fellow, a member of the prestigious Institute of Public Relations Consultants. If we continue reading out Aunty Moji's profile today, we'll never get to the end of it, but just know that she's an excellent person that we all look up to, and she has done so much for the health sector, and we're very, very privileged to have her during this conversation. So Aunty Moji, is a pleasure to have you. And I'll turn to you now with a question, and we hope you can speak to us in a few minutes. The UHC 2023 Forum is an assemblage of a wide array of stakeholders committed to taking advantage of policy window that comes with elections to put UHC on the political front burner. So how are you planning to engage political actors before, during, and after elections to put health on the political front burner? And how do you intend to sustain this towards results? Over to you, Aunty Moji. Do we still have Aunty Moji?
Yes, we do.
Okay. Aunty Moji, you're muted.
Okay, can you hear me now?
Yes, I can. Thank you.
Okay. Good afternoon, and thank you so much for all that you said about me. I was asking if that is that Moji. Seriously, because of the time and the fact that I'm in transition, I'm in Lagos preaching the gospel according to universal health coverage. I'll go straight to the questions that were raised, which is very pertinent. UHC 2023 is a coalition of interest groups in the health sector who have come together to seize a moment that we have now in the country, the moment of political engagement and campaigns to try to accelerate knowledge, information, education, and prioritize health needs of Nigerians. So that's our dream, to actually use this moment of campaign to engage with the citizen, in the sense that the citizens can make demands in terms of prioritizing health delivery service in Nigeria, and speaking to the players themselves, the political class, because we still need the political class to understand how the system runs. And of course, there are some are very aware of the poor, weak system that we have. Some pretend, some would want to work with it, but operating the operationalization of the health system and removing it from the poor state in which we are to a more stable and equitable form is what UHC 2023 is all about. We have started the engagement. What we did was, from the very beginning, we mapped out the engagement with citizens. So it's citizens driven. We have met with politicians themselves. We have advocated. We have met with journalists, the media. We have also met with the CSOs. And so what we're doing is moving forward in terms of engagement with the political players themselves. We do hope that we are at the moment, we're trying to also look at the manifestos of the political parties, analyze them, and give them some measure of visibility for Nigerians to understand so that they can make the right demands. Beyond that, we have actually started action in one-on-one engagement with the politicians themselves. We recently had a good show in Kano where we met some of the gubernatorial candidates, and we are also engaging with other stakeholders so that we can actually bring to fore uh, the challenges, the gaps, the strength of what we have in the health sector. Like I said to you, I'm in Lagos as I speak with you, and I just left a very, very successful meeting where the private sector has adopted, having one primary health care in every local government, 774 local governments local governments in the country. Well, this for me is also encouraging the private sector to also be able to be part of health suppliers, if I can use that word. So it's an all-comer thing. It's something that we look forward that will ensure that health is not swept under the carpet like they always do during electioneering campaigns. We have had some reactions from the political players themselves. We do hope that, going forward, it's not going to be a one-off. We are not planning it to be during the campaigns. We are planning it to also continue the engagement. And we've had some commitment written out that some of the political class have actually signed to. And we hope that we'll be able to track implementation going forward. We hope that it's not just going to be during the elections. As soon as the new governments across board are sworn in, we intend to continue engagement with them so that health begins to take the priority or that it deserves. Oftentimes, people see health from the point of view of just hospitals, availability of hospitals, often that are not manned by human resources. We want to track resources in terms of what is given. We know it's not enough, but how is that expended to ensure that the Nigerians get quality healthcare delivery across board. So this really wraps up exactly what UHC 2023 is all about. But it's a coalition, like I said at the very beginning, and we intend to carry this forward during and after electioneering campaign, and as soon as also we the government. The new administration is sworn in. I'd just like to say here that from the very beginning, we're about a year old. We have collaborated with Chatham House that has been such a wonderful support in terms of aligning with us, our thoughts, and sharing with us other examples across board globally where this has worked. And so we're very excited about what we're doing. The Nigerian Governors Forum is also one of our major collaborators. And this is very important because it's a coalition there where you have some measure of cohesion among the leaders, and we are able to articulate the need to prioritize health. I think the COVID experience has shown Nigeria and, of course, the rest of the world the need to give priority to health. So for now, I would let go, and this is what I'm able to bring forth to this conversation. The conversation continues, and I do hope that everyone that is on board here would also partner with us, those who are not yet there, to know that together would work faster and give equitable and qualitative healthcare delivery to Nigerians going forward. I thank you for listening.
Thank you so much, Aunty Moji. We're quite confident that with all that you're doing, very soon health can begin to take its rightful place in the political front burner and in Nigeria priority list. So right now, we must really appreciate our excellent audience. I actually thought that people were going to leave, but we still have a full room. That shows how committed we are and how interested everyone is in pushing these things forward. So this is a time for question and answers. We have some questions in the chat box, but if in case anyone also wants to raise up a hand and ask a question, we would also take that. So for want of time, because we're trying to wrap up very soon, we would take one question from the chat box. I think there's a question for you, Dr. Kofi, in the chat box. Could you take a look very quickly and respond to it? And then we will take any hand that is raised, and then we'll take a pre-submitted question, and then we'll wrap up.
Okay, thank you so much,
Dr. Kofi,
Frances.
are you there?
Yeah, I'm here. So the first question is the NHIA operational guideline out? And are states supposed to domesticate this operational guideline, or they are supposed to develop their own? So the NHIA operational guideline is actually, we already have an operational guideline. What we are working on is a review of the, hello? What we are working on is a review of the operational guideline to accommodate the changes that are going to happen because of the National Health Insurance Act. And the state health insurance agencies are part and parcel of the committee that's in charge of reviewing this operational guideline. After these, states are supposed to go back and domesticate this guideline in line with their own peculiarities, as I mentioned in my presentation. So states will look at their own political economy and then use the NHIA guideline as a template to review their own and develop their own operational guidelines. The other issue another question was, how is the NHIA DG and his team mitigating the various political economy factors that affect the implementation of the NHIA Act? And I would say that the NHIA boss, my DG, is actually someone who understands the system, and he is also someone who really understands the political economy of this country very well. Not only that, I also want to say that we have a government that is really committed to the level of political commitment to the health sector is enormous, and the goodwill that we enjoy from both the legislative chambers of the National Assembly by the Senate and the House committees on health is unprecedented. So I think with this level of commitments, my DG and his team have been able to really navigate a lot of those factors, and we have actually made sure that we communicate openly and transparently to all stakeholders to ensure they are effective buy-in. Thank you very much.
Very much, Dr. Kofi. So the next question that we want to answer is, there is a question for Dr. Gafar. So Dr. Gafar, could you go ahead and answer?
Sorry, can you let me know what the question is, please?
Okay, so there is a question about what role does climate change play in all of this? So as we consider the current conversations about the nexus between climate change and big demographic change, as well as technological change as an advantage to leverage financing for health. And maybe perhaps you could also reflect a bit about community involvement. One of the things that the research brought out is about community involvement. And someone raised the question about the fact that the Health Sector Reform Committee in Nigeria is considering non-inclusion of community stakeholders. What would you advise based on the findings of this study?
Okay, thank you very much, Frances. Thanks for the participant that asked that question. Let me start from the second one with regards to community involvement and probably non-involvement of a community representative in the big effort towards reforming the health landscape in Nigeria, the presidential initiative. I think part of what we learned from our study was that even looking at the Basic Care Provision Fund, the beneficiary politics was the weakest in terms of involvement, which means in terms of involvement in the community. Fine, civil society were involved in terms of designing of the law and ensuring that it is passed. But when it comes to the nitty-gritty of the design, what shape would the Basic Care Provision Fund take? That involvement was not actually very great. Part of what we found out was that at times, even if there was an effort to involve, community and civil society, non-health experts in the design of the legal framework, policy, and everything. If there is no deliberate effort towards deepening their knowledge of the basic so the subject matter, having them on the table where there is a technical discourse, some of them are actually not find it very, very useful, and some of them will be questioning their participation in the discourse. I think the part of the lessons we've learned is that going forward, if we want to, have a big reform that will bring in stakeholders, the civil society, the beneficiary, and ordinary Nigerians to be part of the process. I think there should be a practical approach towards deepening their knowledge about the subject matter, and they'll be able to relate as much as possible. Because but what the study told us was that it's always very difficult to bring these non-experts to the room if we have not really deepening their knowledge in terms of what the subject matter is and how best can they approach it from their own point of view. So the first question around leveraging climate change, demographic dividends, and everything, I think part of the big picture we have to look at as part of the reform, so that even when we are doing health policy reform, there are external boundaries to health, which we need to take into consideration. A lot of things affect healthcare delivery, politics affect it, social norms and social changes, the climate change, which is a very, very big one, which has a lot of huge implications. I think the implication here is to be holistic in terms of looking at what are the boundaries of engagement that we need to look at. There are a lot of issues about the climate change, has a lot of implications, a lot of extreme of weather and many other things in the climate change that are affecting health. I think it should be part of the discourse to see how best, how do we mitigate the negative impact, but at the same time, how do we take advantage of the positive impact? There are a lot of discussion around climate financing, for instance. What does that mean for us in the health sector? I think this is part of our discourse we should be having. And then demographic dividend, we should be speaking the language that the political class and handlers of the economy understand as much as possible. So if we are talking about demographic dividend, from what perspective, what does that mean for the economy if we're able to achieve the right population and more productive population? I think this is part of a discourse we should be having. But what I'm saying is that our discussion on the health policy should look at the appropriate boundaries that is even beyond the health sector as well. Over for now.
Dr. Gafar, and we're coming to the end of it all. And thank you so much to everyone for listening. Today, we've actually listened to this multi-sectoral,
Sorry, Francis, there are a couple
well-informed
of hands up.
Oh, I didn't see the hands.
Sorry, that Iberia as well, especially. Yeah.
Okay. I can't see the hands. So could you help me call on who the person is, please?
Okay, Dr. Iberia, please.
Okay, thank you. I hope you can hear me clearly.
Yes.
We can hear you.
Go ahead, please. And sorry, I didn't see you. We can't hear you anymore, Dr. Iberia. Uh-oh, I think we lost him.
Can we take Olympus?
Okay. Olympus, please.
All right. Thank you very much. Thank you so much for the presentations and the moderation. I wanted to ask Dr. Karfi if there is a timeline to the review of the operational guideline for the NHIA 2022 that civil society can actually factor, so that we can actually factor that in terms of any engagement or advocacy. And also, well, yeah, let me just ask that because of time, just that. Thank you very much.
Thank you very much. Dr. Kofi, very quick response.
Yeah, so we have a roadmap and timeline. Already the draft guideline is ready. What we are doing now is to, what do you call it, have a review meeting to finalize with all the stakeholders. So I think in the few weeks or months, in the few weeks, the guideline, in the few weeks, the guideline will be out. Yeah.
Dr. Kofi, Ebere, are you back? Well, you're still breaking off and we can't hear you. Ebere, are you there? Oh, so sorry about that. Please, could you put your comments in the chat box because we can't hear you. We're so sorry you couldn't get to ask your question or make your contribution. Right, so we have to wrap up because it was never our intention to keep people beyond 90 minutes, but seeing as we still have a full room, we must really thank you. Today, you've listened to this high level of our panelists who have shared a lot of experiences, and we've learned a lot of lessons today. We've learned about the importance of political economy application in any health reforms that we're going to make. And one of the things that is being said, or that is commonly said, is that a wise person learns from other people's mistakes. So we mustn't go back to the same old mistakes that we made in the past. During Dr. Gafa's presentation, something very important came out about the need for the trade-off between speed of implementation, inclusion of everybody that is important, as well as the best design that will give the best results. So it's very important to actually anticipate these challenges and try as much as possible to come to a good place before we embark on policies. Prof. Dina also very much highlighted the importance of politically informed policy. And she mentioned something very important, that political economy doesn't need to be a constraint, but it could be an opportunity if we know what we're doing. So we need to be politically savvy as we go about reforms. And she also mentioned something very important, that alliances are not permanent. Like an old professor of mine would say, there are no permanent friends and no permanent enemies. So people who are allies could also turn in another direction tomorrow. So we must anticipate this. And she also mentioned the very important thing about capacity strengthening, as well as being proactive rather than responsive when we're embarking on policy reforms. Prof. Aliko also had some very important highlights about why we need to focus on strengths rather than weaknesses. But this doesn't mean that we're going to be oblivious to the risks that lie herein, because he has outlined a very important UHC platform that the Chatham House has put in place to make sure that we prepare and that we engage politically, including the importance of galvanizing political leadership and finding UHC champions while leveraging on political actors across board and institutions to make sure that we drive these reforms. Dr. Kofi, of course, shared his experience about how we have leveraged on existing experiences and learnings from this political economy analysis. And right now, the National Health Insurance Authority is doing things better. There's more use of evidence for decision-making. There's more accountability being built in. There's outcome monitoring being built in. And they are actually applying lessons and anticipating issues as they go along. And we also heard from the implementer's perspective about the need for evidence-based application while leveraging existing ecosystems, because we cannot do it alone. And of course, the important political engagement and whole of systems approach that needs to happen. And then finally, Antimoji actually very well highlighted the importance of taking advantage of opportunities. So right now we're in an election period, and she and other like-minded stakeholders, and we invite everyone here to join us in this mission of making health take its rightful place in this country with regards to politics, with regards to all economic discussions and everything that is happening. How do we bring health to its rightful place so that we can actually begin to advance on this journey of universal health coverage and in trying to keep with the SDGs. I thank you so much once more. I must thank the excellent panelists who have actually shared their wealth of experience with us. I thank the excellent audience, and we must apologize because we thought we would have more time for questions and answers, but please feel free to reach out to any of the panelists here subsequently. And then of course, just to say that this is not a one-off. So this policy discourse will continue to happen. And then we look forward to opportunities of actually seeing civil society engage during this election period to make sure that health is on the front burner. Thank you so much, everyone. I can see Dr. Gafa is like, he wants to say a special thank you. Dr. Gafar.
Okay, I think you've said it all, Francis. I'll use this opportunity to thank everyone, and I hope you will join us later when we come with another episode of this policy discourse. I will thank our panelists, Professor Aliko, Professor Dina, Kufri, and Timoji, and our own LHSS Chief of Party, Bola, for that great presentation. Thank you very much, and thank you to Francis for great moderation.
Thank you. Anyone who is still around, could people put on their cameras for a quick picture? Ismail, can you help us take a quick screenshot? Please let me know when you're done.
I can
You're
only
see
Gafar. It's only Gafar we are seeing.
Exactly. I can only see it.
Oh my goodness. Ismail, are you there?
It's all right. Perhaps we get
Ismail is there. He's trying to get the technology right.
Right. Okay.
Eileen, it's been done.
Okay.
It's been done. Okay, great. Thank you so much, everyone. Well done.
Bye.
Bye.
Thank you
very much. Have a good day.
Yes,
thank you
thanks
very
a
much.
lot, Prof. King. Thanks,
Thank you.
Prof. Aliko.
Bye.
Thanks, everyone. Bye.
Thank you, Francis.
And thank you very much, Dina. Highly appreciated.
I missed my next meeting to start because I'm so fascinated by Nigeria.
Oh, great. I'm sorry about that.
No, don't worry. It's interesting for me. So much learning. We'll be in touch about these issues. Yeah.
Sure. Thank you very much. Thank you.
very
Bye
much.
for now.
Bye-bye.
Yeah. Bye.